Hello, everyone, and welcome to this HSJ webinar exploring how local health and care economies might best develop a shared understanding of COVID and other pressures. I'm Claire Reid, a contributor to HSJ and your chair for today's event, which is being run in association with Graphnet. I'm pleased to be joined by Joe Rafferty, Chief Executive of Mersey Care Foundation Trust, by his colleague Jim Hughes, who is Strategic Advisor for Digital Programmes, by Becky Morby, Professor in Health System Innovations at London South Bank University, and by Marcus Bolton, who's Director of Graphnet Health. Together, we are going to be discussing an issue which could barely be more topical. How do local health and care economies build a shared understanding of the pressures in their areas? Clearly, the first wave of COVID brought this to the fore, but with a challenging winter ahead, it remains a central challenge. As we've all seen, the picture with COVID in any given geographical area can change quickly. In turn, changes may need to be made quickly to which health and care services are delivered where and how, with difficult decisions to be made about prioritisation. To be able to make informed choices about how best to manage the health of a population, there is a need for a shared understanding of which pressures and caseloads exist and where. But how best to generate such an understanding? Which parties need to be involved? Which information is important to which groups? And how can any worries about information governance be overcome? Those are among the questions we're going to be discussing today. And for those of you watching live, you can suggest what other areas we might consider. If there's anything you would like to ask the panel, please do submit a question. To do so, just follow the prompts on your screen. I'll bring in thoughts from the viewers as the debate progresses. To answer at the outset one question that we're most commonly asked, yes, don't worry, an on-demand recording of the webinar will be made available in the coming days, and we'll email a link when it is available. Chair's privilege means I get to kick off the questions, though, and I'd like to start with Joe, if I may. Joe, I know this idea of building a shared understanding of pressures in the area is one you and colleagues have been working on very hard in recent months, and we're of course all aware of the real challenges with COVID in Liverpool. Tell us a little bit more about how Mersey Care and other organisations in your area have worked together to get this shared understanding of where things stand.
Yes, thanks, Claire. I mean, this is in part a piece of work that I suppose we've driven from Mersey Care, but it has been about our system in Cheshire and Merseyside. And the reason it's been about our system is, as well as being Chief Executive of Mersey Care, I've also led the out-of-hospital cell during COVID. And sort of on day one, when I unexpectedly found myself doing this task, what was really clear to me was we were drowned in data, but actually hardly any of it was the data I needed to have. And the data that I could have wasn't particularly well joined up. So it didn't, in essence, tell a story. It was retrospective. So the tools that really we needed as a system to respond to COVID were just out of reach. And what was very clear, I think, in the cold light of dawn now, in reflection, is we've had some amazing digital technical innovations take place in Cheshire and Merseyside. Really great stuff. But in essence, it's been sort of driven by the available technology at the time rather than by strategy and need, you know. So we were in that curious position of having been able to look in on technical changes that were clearly valuable in their own right, but in essence embedded a sort of largely a view of how to make the current system work better, rather than how to create the system that we absolutely need, given the pressures we had. And if you think about managing COVID, it is the story of population health management. We keep talking about population health management in sometimes an abstract way. This is an absolute requirement to do population health management. And that's when we started to talk about the need effectively for a persistent longitudinal care record. And colleagues will talk a lot more about that and know a lot more about that than I do. But we were able to, with some assistance from NHSX, move very rapidly onto a platform that allowed us to think about connecting our data really differently, actually using COVID use cases, which I think maybe Jim will talk about, in a way that allowed us to begin to pick up the data we needed in pretty close to real time. And if I give you just a very quick example, people will have heard of the work we've done in Liverpool around what has been called mass testing, but actually we have always referred to as smart testing. So systematic, meaningful, repeat testing. And we were able to do that largely because we'd stood up this new platform for us. And that allowed us to, every half hour, see where we were getting lateral flow tests in, to see, in pretty darn close to real time, how this information was emerging, which allows us then to meaningfully manage in a population health context. And actually, the other really important thing in this, as we watched those tests emerge over the period of a week or so, what we could tell was who wasn't being tested, not just who was being tested. And actually, that's a great big hole in our knowledge, generally speaking. So what we're able to do is think about moving our testing from that sort of notion of mass testing, where you're going to go and test everybody, actually to the notion of smart testing. So where were we going to create engagement pressures using community activists and all sorts of approaches to say these are the populations we need to get into? So that for me is true population health management in action. The delivery of that information gives us insights, and this is what this is about. This is about insights and actionable information that allows us to change the deal for the population. And in parallel, I suppose what I'd been observing was an absolute mass of really serious endeavor, but, and I don't mean this in any sort of critical way, but led by people who were technology enthusiasts rather than necessarily by people who were asking questions about how best do we serve A, the population, and B, the patient and the person. And I think, where I'll drop it off now is to say, I think sometimes we get into this slightly, defining the difference between a unicorn and a leprechaun. The truth is it doesn't matter because they're not real issues. The difference between population health and direct care. I mean, these are the same things. They are just slightly different optics in how to view it. And I suppose for us, COVID brought into sharp relief the necessity to begin to connect that equation. And of course, there is an awful lot of technical information governance, critical stuff that goes underneath this that colleagues will talk about. But what has made the difference, I think, has been taking a strategic view to say we need new insights in order to deliver care in real time to our population in a way that begins to protect it. And yeah, I mean, most people would be familiar with the results in Liverpool, but in a very short period of time, we moved from a prevalence of hundreds and hundreds per 100,000 population down to, if you now look at an adjusted figure, to around 50 per 100,000. So it's been a stunning success. It wasn't about providing lateral flow devices. That was part of it. What really made this thing was being able to connect our data in a way that we've never done before.
That's really powerful. Thank you so much, Joe, for talking us through that. So many important points. The difference between data and insight. I think often they're seen as synonymous, aren't they? And exactly as you've described, they're absolutely not. And similarly, as you were saying, the idea of technology only being useful if it's embedded in a desire to get a greater clinical understanding or a greater understanding of the population you serve. It's a brilliant segue into Jim, because obviously Jim was the one who was responsible for making all the tech happen. So Jim, tell us a little bit more about how you achieved what Joe has sort of just been describing, and what you think have been the biggest recent advances around sort of creating this shared understanding that Joe was talking about.
Yeah, thanks very much, Claire. I guess for me, the biggest single thing was not technology, and this plays into Joe's point about the leadership amongst the health and care partners that we worked with, because we have something like 400 plus data controllers, each of whom has to have a trusted relationship if you're using their data in a collected and integrated way. And obviously the pandemic did bring people together around a single cause, and that helped. But nevertheless, those relationships had to be established, and that was a key thing. But in terms of the technical part of it, I think in order to stand something up as a technical resource, and we did that between May and we were operational by the end of August, with a fully integrated and all the data in for a health and care population health and care record. The main issue was that we were able to partner with an organisation that had an established process in place for the collection of data, and these are very technical issues in terms of getting the different data feeds in and being able to reconcile them and curate them and index them, and all of that stuff that happens in warehousing, and that this was in a cloud environment, so that we weren't concerned about the volume of data, and over that period of time we've added to that volume of data, because not only including all of those data controllers, but also bringing in all of the national data from NHS Digital. So that was a major piece, was actually having a secure, stable, reliable platform on which you could build. And I guess the other thing is that having developed the platform, how do you make the data available in a way that is intuitive to any user? And the thing that's made the most difference there was around the use of the Microsoft Power BI tools, in order that we could pass that information out as a standard report, but one on which individuals or cells or organizations could filter that to their own needs. And in addition to that, we set up a daily reporting system by just taking one snapshot through a PDF. And I suppose what's interesting to me is that this week I sat on the Cheshire, one of the Cheshire LRF cells, and they spent the first half hour of the meeting looking at these PDFs, talking about what that meant for their trusts, how that compared, what that meant for their population, how that compared to other areas, what their numbers meant, what the trends were, and then taking action from it. And we've called this piece of work Combined Intelligence for Population Health Action. The key thing for me was not just that they said great charts. The key thing for me was that they were taking action from the intelligence that they received. So I guess that's that. They're the other technology pieces. There's another technology piece, which is how do you stand something up in 5 months that might normally take, I don't know, 18. Marcus will tell me 18 months. I don't know. And remarkably, that is around the use of technologies such as we're using today. In that, for a very large geography, I could be in effect in Macclesfield one day, and and within an hour I could be in Bootle, and having 2 separate meetings. Right, that doesn't take me a day. That I can be doing 5 of those, 6 of those in a day, in terms of engaging with people, and in terms of getting program teams together, in terms of getting the right expertise together, and that bringing together of expertise and building the relationships was actually a massive benefit that everyone was accessing through whatever it may, whatever platform, Teams or Skype or Zoom or whatever it might to be. So I suppose they're the technologies that I would pick out, and the context of them.
That's great. Thanks so much, Jim. You mentioned LRF cells. What does LRF?
Sorry, Local Resilience Forum.
Excellent.
Oh gosh, we get so used to this. Yeah,
Absolutely. Of course we do. Of course we do.
I do apologise. Local
No,
Resilience
you don't have to
Forum.
apologise at all. There are, we all know that the NHS is acronym centric, but I just wanted to explain it for anyone who like me wasn't 100% sure.
Yeah, of course.
That's great. Thank you so much, Jim. Just a quick reminder to our audience. I'm going to continue with our questions. Obviously to come to Becky and Marcus, but a quick reminder to the audience. After that, I'll be coming to audience questions. We've already got some in, but if you have something you want to ask, don't be shy. Just pop it in the box at the bottom of the screen. I tend to think audience members often think, oh, well, I won't ask so-and-so just in case they come to it. Don't worry about that. Put it in. If we've come to it, all well and good. And if we haven't, your question will mean we can. Becky, can I come over to you now? Obviously, Professor in Health Systems Innovation, so this is a key area of research for you and something that you'll have looked at in the round, as it were, across, I imagine, the country. I wonder what your thoughts are on how innovation may have accelerated in the past few months with COVID, and whether we can sustain that progress, and crucially, given that the area that we're discussing today, whether these sort of shared understandings of system pressures that have been developed during the crisis are likely to continue.
Thank you, and it's been really great to listen to our previous two speakers. I think what really struck me from Joe was the importance of having real-time data. So starting with a sort of curiosity about what's really happening here and now, rather than a set of fantasies and assumptions. And one of the so-called benefits of COVID is it being new. So we had to start with no knowledge, and we had to go discover it and find it. And actually, that's a lesson learned for a lot of what we do. So what I see in the NHS, and we've all been part of it for a very, very long time, are there all sorts of patterns and behaviours and ways of operating around here that haven't necessarily been questioned. And it wasn't just within those people who were experiencing COVID, but across the whole, questions had to be asked. And whether it's not just your meetings about putting in IT, it's also how do we run an outpatients? How do we run a GP practice? So we very early on ran a survey about, so what innovations are you seeing that you don't want to go away, that you want to stick? And the report was 10 leaps forward in the pandemic, innovations in the NHS. And we've done a subsequent one about what has stuck. So let's just start with the innovations that we saw during the pandemic in places where it was working, i.e. those staff working there were reporting that things are working well. And so it isn't just the data, it's the culture that enables you to use the data to question and learn and change. So what really helps people feel like they could properly act as professionals in this situation with data. So obviously having data was the first thing, and the prevalence and the ability to get data was loosened up dramatically over that period of time. Data around real-time admits to A&E, data around from general practice, the people who were sheltered was starting to be shared with local government, with local communities, because how do you solve the problem of people who are struggling or on their own? We need to find them, and we need to share that knowledge, and we need to know about it. And somehow we managed to loosen up stuff that has always been precious and difficult in ours. So the availability, the collaboration, the understanding that in order to reach people, we had to understand who they were and where they were. And for, our ICU clinicians, their WhatsApps with colleagues in France and Italy, phenomenal data sharing for learning. So there was an attitude which was about we have to adapt quickly, and that opened up people's mentality. But it also meant that we were in service as a system to clinicians making really difficult decisions with citizens and communities, and Joe making really great decisions with his local authority and populations, that the task was the most important thing, being really, really focused on that and galvanizing our collective effort around it. So what it meant was, and I'll take, ICU is a nice little example really, is that, the respiratory physicians were teaching the ICU consultants everything they knew about respiratory. People were rapidly learning. But of course, that's fantastic at the time. They were sharing their data, they were sharing their knowledge. Professionals were really stepping up and being professionals. To be professional, you have to have really great data. you have to be open to scrutiny, and you have to properly collaborate in service to need. And somehow the system draws us back away from that very quickly. So when you look at the things that mattered, the culture that mattered, it was people at the top asking folk at the front line, how can we help? What matters? What do you need? What's going on here? Data about what was really happening. A real collaborative learning professional model that was opened up, and the NHS asking for help where it needed it. So citizens were stepping up and stepping into spaces where the NHS said, we can't do this, we need help with, is anybody out there? And the communities went, yeah, we're here, we'll help. We'll step into that space, we'll help with sheltered folks, we'll help with people that need to get their medicines, we'll help. And it provided a bit of an opportunity, opened up some space, and it enabled great teams to develop. People started doing things like checking in regularly as a team. Now, we all work with both hospitals and community services and general practice, and we'll know that in some places across all of those, teams are fabulous. They check in the morning, they look after each other, they check out. Some general practices, hospital teams don't do that at all. They don't do huddles, they don't do any sort of how are you? How's your day? How are you managing type questions? So the culture was of learning, collaboration, being in support of the task. Now, what's happened since, when we've gone back and had a look at the survey, is that the thing that's stuck is the digi-tools. The things that are not sticking are all the cultural stuff that enables people to use those well. So when you look at when I looked at the 10 leaps, what I saw was all the conditions that we see in high-performing health systems, be it Intermountain, Alaska, Jönköping, Buurtzorg, we were suddenly sort of there doing the things that you see in those cultures. But interestingly enough, as we step away from it, as things have become normalized, the old world bites back, and it's been very hard for teams to hang on to some of those cultures that really help you make really effective decisions. So what we had the opportunity for, and still have the opportunity for, is to start with need, not start with demand. Joe's situation, go in, find out what is it we need. So for instance, in general practice, what does it show in general practice? Well, what we know is that young folk don't access general practice anywhere near as much as they probably should. It's a bit unclear actually around young people and anxiety, whose job it is to deal with that. It sort of falls between stools. What there is and was an opportunity to do was to start looking at general practice and differentiating the list, saying who comes and why. And there was an opportunity, and still is an opportunity to do that, because once you start looking at the list, what you find is that we've got people who are bouncing around the system, that sort of PCN work. We've got young folks who we suddenly started worrying about because the schools were worrying about them. The GPs were saying, actually, we've got a few, actually, what's going on here? The schools were asking GPs, saying, how do we reach these vulnerable youngsters? The free school meals, there's a lot of folks gathering around some of the needs that have been existent in the system for a very long time, but not probably fully addressed. So childhood poverty, our colleagues from Black and ethnic minority populations with health inequalities. There's a real chance to say, if we really, really want to address and ensure that we have a system that is about equality, what is the need and how are we addressing that in a way that we did early on around, so what's going on with COVID? And how do we find it, and how do we address it, and how do we build services around it? So I think there's some lessons learned there, Claire, but very particularly the things that enabled clinicians particularly to do fantastic work and be the best they could was that the sort of taking away of some of the pain around specialism and generalism, so that they were able to say, actually, we just need to use both in service to the task, and we'll work out what that means afterwards. Really great data, support for the teams, and people saying, are you okay? What can we do for you? How are you today? And some sense of being thanked. People walking around saying thank you was really fabulous. So very small things, most of which don't cost a lot of money. In fact, some of it, no money at all, are about how do we just reframe the culture so that we are open to the data that we could then ask for proactively about need, both by asking citizens and people, as well as some of that population data.
That's great. Thank you so much, Becky. What a fascinating follow-on from what Joe and Jim were talking about. And as you say, that the way in which culture is absolutely central to this. And it strikes me when both Joe and Jim were talking, they kept using the word relationships, and they kept using the word of kind of building that. So that culture piece that you were talking about really complements that beautifully. Thanks, Becky. I want to come on to Marcus now. Obviously, Marcus, you sit on the supplier side of the equation and worked with Joe and Jim on setting up the system they've been describing. I wonder if you can tell us a little about your perspectives on how organisations can best use technology and data to develop these shared understandings. What characterises organisations that do this really well? What sort of specific data is being shared in the setup that Joe and Jim spoke about, and why? Becky, if I can just ask you to mute, you would. No problem at all. Over to you, Marcus.
I mean, it's quite interesting times, really. So we've been producing these population health systems for many, many years, so 15, 20 years. And what's happened in the last few months is really a big change in use. So people used to use them for quite kind of measured and kind of cumbersome, not cumbersome, but sort of slow programs of work. So they were interested in what was happening in diabetes, so that they would have maybe a 12-month project set up to look at diabetes and the different pathways for that, and to sort of see how that would work. And effectively the IT and the data which would support, you know, quite long-term projects and studies. So what's changed is with COVID is all of a sudden people need to know all sorts of stuff, and they want to know it right now. And I don't think we've ever seen that before in terms of the types of demand for information that are coming through now, and really unexpected. I mean, nobody knew that BAME was an issue, and all of a sudden it was the big thing, and everybody wanted to know how the interaction between healthcare and BAME status, for example. We currently have quite a lot of work going on with the COVID vaccinations, COVID test results, and the interactions between those. So all sorts of data demands coming. So, and what's interesting is that people get quite hung up on the technology of these sorts of data sharing. So if you see what we've done, I mean, if you look at Cheshire, for example, I mean, we've got, I think it's around, someone will correct me, but it's around 400 GP practices, 13 acute sites. There's probably maybe 5 to 10 councils. We have data coming in from a lot of the national data that's coming in from different places, 999 data, 111 data, out of hours data. So all of that data needs to come from all those sources and come into a single system in order to give you that longitudinal record. Well, actually, the mechanics of that now are really reasonably straightforward. So we put all of that together in just a few months. So I think people tend to look at these projects and think about them as technical projects. We've cracked all that, so we can do that very quickly. And you shouldn't think about this as a major technical project, because there's a standard deployment methodology to go with it. So I think the key here is actually, and it's, I think it's a point that Joe mentioned earlier on, and the fact Joe's on this call, is that the project is led by the service and not by the technocrats or the people that are, you know, doing all the IT and the joining up and all the rest of it. So we are fulfilling a demand that the service has recognised. So they have a massive waiting list problem all over the place at the moment. COVID has put waiting lists into all sorts of disarray. What are we going to do about that? It's going to be quite innovative, and data is what's required to resolve it. And it's the data requirement, why they need the data, that's driving the project, rather than the project doing something wonderful technical that we're hoping someone uses at some point. So I think that's a huge point for me, and one of the reasons I'm pleased that also Journal are interested in this, because your readership is effectively the execs rather than the IT people, and that's kind of needs to come from. I think the second point here, so we now have 20 million citizens. So that's about a third of the UK running these shared record population health systems. So we're starting to build a community of people that kind of work on this stuff. And each part of that community is tending to do different things with it. So Frimley at the moment is heavily into pulse oximetry and virtual clinics. And they're using the population health system to identify the right patients, to give the real time and to kind of work through that. We're seeing, you know, a load of programs through the CIPFA program here, you know, particularly, as I said earlier on, around the mass testing program, etc. And what we like to see, and what's important, is that people focus on these use cases, technology, and that they're able to share these use cases across the care across the user base. So we have kind of regular meetings with people. We're trying to write stuff up. We're doing videos, preparing case studies, so that people can, because it's identifying how this data helps and then telling other people how it helps, rather than everybody having to come up with the ideas on their own and repeating the same ideas again and again and again. So I think that's kind of is very important. And then the last thing is this governance. So the COVID and the COPI notice has helped on governance here, because it's given a legal basis for sharing data that would normally take a lot more to kind of get through, finding it's COVID related. We have 20 million longitudinal records, so there is no problem regarding safety, governance, usage, etc. But it's really, really important to get it right, because patients and people and GPs, etc., are trusting us with their data, to hold their data correctly and manage it correctly. And we can't abuse that trust, so we have to make sure that the governance is in place. And Cheshire and Mersey have done a really good job of putting together a very solid, completely defendable governance structure to make decisions around data and to use data safely. And I think the big drive now is to make sure that some of these data uses survive COPI, because it's actually essential for managing patients in so many ways. So COVID might have been an enabler, but it's just part of that problem, really. So does that answer the question? I've got lost on your question. Sorry.
It does. No, that's brilliant, Marcus. That's absolutely great. Thank you. And speaking of questions, we're going to go into audience questions now. Again, a quick reminder: if you do have something you want to ask, just pop it into the box on your screen. Marcus, I'm going to come back to you first off, and then come to you, Jim, on this one. This is from Ethar. Ethar, I hope I've pronounced your name correctly. Please forgive me if I haven't. Ethar talks about the idea that often suboptimal situations are enabled by siloed procurement, where something is only focusing on an individual output in one area, not systemically. Asking what can procurement do to move towards getting to more systemic ways of getting the systems and technologies needed. Marcus, talk to us a little about how your shared solutions that you've described are procured. Where does responsibility generally fall for a procurement? Is it across several organisations?
Yeah, so first of all, these are clearly health system type problems. So one of the problems that we get is that when someone wants to do a shared record, there are somewhere between 10 and 60 major organisations involved, plus hundreds of GP practices. So who buys it, who pays for it, etc. So this is simplifying really with the ICS and STP position has simplified this, where people are now buying in bigger groups, and it makes super sense to run these things across decent sized populations. So Manchester, for example, is running with nearly 3 million citizens, 2.6, I think it is, in Cheshire and Mersey. Thames Valley is 3.8, which is joining together Buckinghamshire, Oxfordshire, etc. So the first thing I'd say, I think it is useful to take these systems on a bigger footprint, but providing that you don't get stuck into 5 years of politics where everybody's trying to do their own thing, and the bigger the footprint, the more existing people will be trying to do something smaller on a different area. So therefore, there'll be the kind of not invented here thing, which you can get lost with. Procurement is normally done, it just varies. In some places, an acute hospital takes the lead. In other places, it's a CCG. And I don't think it really matters about that. I mean, people have got mechanics for procuring in whatever footprint they choose to use, really.
That's great. Thanks, Marcus. Jim, can I come to you? Tell us about how it was procured in your area. And Marcus, just a reminder to mute, if you would.
Yeah, so the path that we took wasn't conventional procurement. It was through the time at COVID, and it was through a business case that we presented to NHSX, who approved the principle of what we were aiming to do, and then took that to the on our behalf took that to DHSC COVID panel. So that wasn't conventional procurement, but I think what we do, and that was for a period up till next March. I think what we face at the moment is we face a procurement path now, because I think so much has been achieved through the program, and so much the recognition of population health, both in the general, not just in the COVID specific, has become such a compelling position that as we move forward, it will be through our ICS, our health and care partnership, at that regional level, but and then those financial arrangements will be put in place. I think one of the things that we have learned in terms of how that would be, how you'd get the individual place-based systems to understand their role in this, is that we've set up a target operating model for this population health, which means it can be purchased through the ICS, but it can be its use is federated into the different places. So we have to recognise that the position at which the different parts of the system use the data, that their ownership of it is felt in the place where they operate with their very local, their own local authority, their trusts, their community, their mental health, their GPs. Whereas the storage of the data is at the regional level and procured regionally, but that the operating model is recognises that is federated into place-based action. So that we don't just think of it as a kind of monolith. We have to be more sophisticated in how we describe the subsystem, the subsystem needs.
That's great. Thanks so much, Jim. Next question, which I'm going to come to Joe on first, and then to Becky, if I may. Lorraine asks, what are the next priorities that this dynamic clinical intelligence can be applied to? So Joe, tell us a little about what the longer term plans are for making the most of the systems that you've set up, obviously with a specific view to COVID in the short term. How do you anticipate that it will be used in the longer term for population health management in general?
Yeah, so it's a great question. Hello, Lorraine. I think what it gives us this, I think, now is an opportunity to really think about the mechanisms about how we bring population health management to life. I mean, for a few years, it's been really interesting to look in on the narrative that has emerged and to look at ICS development with a strong sense of, well, we're absolutely going to tackle inequality. But in truth, when you analyze the mechanisms that have been available across our systems, often they're heavily siloed. So stuff we do in the NHS, but 70% of what happens in somebody's health and care world is determined in other places. So, I think what I can see is the movement towards a really significant collaborative. And this is, I think, sort of what Jim referred to in terms of data turning into insight and intelligence, and that been usable at the most devolved point in the system, but also equally aggregatable to any point right up to the ICS. And indeed, if you think about Marcus's point about 20 million people connected through these sorts of systems, you could envisage this being aggregatable up to a national level. So I think if you read some of the ICS documentation that's out there, they often talk about a system by default. And that's a really interesting, but for me, slightly confusing piece of language. And in my mind, I can see the system by default being an intelligent system, which might be a single patient sat in front of a healthcare practitioner or a social care practitioner anywhere in our system. But equally, we should be able to draw from that point right out into the population meaning for that patient with, presentation X. And I suppose where I really want to see this go is to the points that Becky talked about. I think where there was that sort of triangle between inequality, equality, and equity, which I think continues to escape health services enormously because we're driven by demand rather than need. And understanding our need more precisely is really important. So where we've already talked about in Cheshire and Mersey is the notion of a civic data cooperative. And that's not just a notion, that's a real thing that is now starting to take shape. It's made possible because of the involvement of GPs in all of this. It's made possible probably more profoundly by the involvement of local government and social care data. But of course, you've got education data, you've got employment data, there's all sorts of stuff that then begins to give us a different view of people's lives. So one example where we've already taken that is the notion of complex lives. So people who are, let's say, super users of all public services, physical health, mental health, police, social care, education. We have certainly in Liverpool, looked at people with one major physical healthcare problem, one major mental health problem, and just one of 7 other criteria, unemployment, substance misuse, domestic violence. You can pull off that sort of menu. And actually what we've been able to do is move down to 3,000 people who consume a huge amount of resource and who we publicly spend a great deal of money in providing essential services to those folks. But what's really, really clear is it's siloed through multiple different providers. And in a world where each public healthcare pound is absolutely critical, we need new insights, new mechanisms to say, well, actually, not only can we do this more cost effectively, but actually we can do it a heck of a lot better with real better long-term outcomes for the people involved and a measurable, objectifiable way of demonstrating that we've done this right. And I think these tools now give us an opportunity to operate in that type of way. The critical piece here is to remember that this is all about people's data, and we need to treat that as absolutely sacrosanct in this respect. And that's one of the things I'm actually most proud of in this is in a 5-month stand-up, we've kept that whole data protection and confidentiality piece absolutely, authentically right at the heart of what we've done. And provided we do that, I think that's the sort of long-term vision. I think we can deliver that vision rather than just talk about it.
That's great. Thank you so much, Joe. I cannot believe we're down to the last 3 minutes, so I'm going to have to do that horrible thing of coming to you, Becky, and asking you to be relatively brief, if you would. But I wonder if you can build on what Joe has just said and in response to Lorraine's question about what are the next priorities from the research that you've done about, as you touched on, the surveys that you've been doing about the things that might persist and where you think we might go next.
So sort of fully in agreement with Joe, but I think there's some things we can do now which might be even paper-based whilst the systems are catching up, and great when the systems do catch up. The first thing is we don't really have enough data scientists in the system. We have lots of data analysts. So people that will help you be curious about what's going on around here, will ask you very relevant questions and will help provide the data to support those. We've got a lot of people scrabbling around trying to do run charts and tally sheets and God knows what else. We don't have the data scientists, so we haven't invested in that, and we really need that. So that's number one. Second thing is GPs need to differentiate their lists, and they don't do it. So we're busy putting in loads of extended roles at the moment, additional roles, without really understanding needs. So there are some very simple things you can do about people that turn up frequently. Joe's talked about the very, very high superattenders. The travesty is not just the money. The travesty is their needs aren't being met as well, aren't they, Joe? They're just bouncing around, and it's a terrible cost to them and their families that is incredibly unmeasured. So those feet need proper wrapping around, proper case management work. But at a general practice level, of the people that turn up frequently, GPs don't know why they turn up. Mostly 40%, it's usually struggling with life. Nothing a GP appointment can do anything about. We need to understand the people that turn up, and not at the superattender, but at the next level down in general practice. We need to understand who needs continuity. It's all known. There's all the evidence about this. But is general practice pulling off those folks saying, actually, these people need a half 1 hour appointment once a month? That will save loads of money. And then once you start doing all of that, you can start working out what additional roles you need. So at the moment, we're slapping roles into general practice without really, really spending time looking at their data and saying, What is their need? Who is turning up and why? And how do we design around that? And there is a real opportunity to do this now, but primary care has been massively left out of the equation overall in the NHS, not in Joe's work, but overall in the NHS. They are scrabbling around with nobody to help them do this, and they really need support.
Thanks, Becky, and thanks so much for keeping it concise, because I know it's so difficult. These are really complex and really important issues, so I very much appreciate you keeping it concise. Unbelievably, our time is up. It seems to have zoomed by for me. I think really our discussion today has made so clear the real value of developing these shared understandings of data. But I think it's also made clear, as we've just touched on with Joe and Becky, that there's so much more to be done and so much more value that we can get from these kind of setups. As I say, unfortunately, our time's now up, so I need to draw things to a close, but I can't do so without thanking our panelists, Joe, Jim, Becky, Marcus, as well as Graphnet, of course, for supporting today's event. And thanks, of course, to you for viewing the webinar. I hope you found it an interesting and useful discussion. Goodbye for now.